Hello, I'm Dennis Holmes. It's a pleasure to join you today to discuss the impact of delay in treatment after a diagnosis of breast cancer. I'm a breast cancer surgeon and cancer researcher based in the Los Angeles area, and the impact of delay in treatment, particularly the impact of delay on survival, has been an area of great interest to me. I've looked to find solutions for this, and so I'd like to spend this time sharing with you not only the problem, but a solution that we had the opportunity to introduce and demonstrate in the context of a clinical trial, which I'll share with you by the end of the presentation. Now, as I said, I've been in practice for about 20 years, and one common theme across this experience is that anxiety related to a diagnosis or to the delay in treatment has been a great burden that many women have had to bear. They have to wait to have the biopsies performed. There's uncertainty about that. Once a diagnosis is made, there's this anxious wait until they undergo treatment. And a lot of that anxiety is shared by the physicians, myself and others, who want to get the patients through the process as efficiently as possible. Now, we've also had concerns over the years that those delays, particularly when the delays are significant, could sometimes impact their survival. It was a concern, a suspicion that we had, but we never really had hard proof that delays clearly, consistently compromise survival, at least not until 2015, when a colleague of mine, Richard Bleecker, published this paper along with his colleagues, looking at the time to surgery and breast cancer survival in the United States. This was published online in 2015. And what they did was to look at two national cancer databases, the SEER Medicare cohort database and the National Cancer Database, about 200,000 women with stage 1, stage 2, and non-inflammatory stage 3 breast cancer. And they looked at the time interval from the diagnosis of breast cancer by needle biopsy and the time of surgery to see if there was any correlation between delays in that interval and survival. This image here summarizes the key findings of the publication. Looking at the time from needle biopsy to surgery, the first finding was that beyond 2 months, each additional 1 month delay led to a 10 to 15% relative reduction in survival. So from 60 to 90 days, there was a 10 to 15% relative reduction in overall survival. From 90 to 120 days, there was an additional 10 to 15% reduction in overall survival. And the second finding was these reductions in survival were primarily seen in patients with stage 1 and stage 2 breast cancers. It wasn't the stage 3 breast cancers that where it was prominent. It was in the early stage breast cancer patients where time mattered most, where time delays correlated with worse survival. Now, since Bleecker published this paper, there were a number of other publications that came out, a good 24, that showed essentially the same thing, looking at different populations. There's one here from a universal healthcare system. So within a single system, they looked at time interval and its association with survival and found, again, that prolongation of the time interval between biopsy and surgery led to a compromise in overall survival. Studies also looked at the impact of age. It was also true for young women, just as it was for older women. And then more recently, Deborah Pratt and colleagues looked at the time of completion of breast cancer treatment and survival, looking at the interval between surgery and completion of chemotherapy for patients that are receiving chemotherapy, surgery, and radiotherapy, for example. The point was that the total treatment interval from the start of the treatment, surgery, and the completion of adjuvant therapy had a correlation with survival. When that interval exceeded 38 weeks, or about 8 months, there was a 6.5% reduction in survival amongst those patients. So efficient care mattered. It was important to get it started, but it was also important to complete it in a timely manner because delays in the completion, according to this publication, also compromise survival. This study is actually a meta-analysis. It looked at all of the publications up to 2020, all of the publications for breast cancer, but other cancers that correlated time to treatment and survival, and found consistently that time to treatment mattered for a range of cancers. Our focus here is on breast cancer, but this publication looked at bladder cancer, colorectal cancer, head and neck cancer, and others. And there was a consistent finding that the time from diagnosis to surgery mattered, and the time from surgery to completion or surgery to initiation of adjuvant therapy mattered. So time matters even in terms of survival for patients diagnosed with breast cancer or being worked up for breast cancer. This publication, just for completeness, was actually a publication that looked at the time interval from an abnormal mammogram, like a suspicious finding, to the time of a biopsy for someone who was ultimately diagnosed with breast cancer. And specifically for patients with breast cancer, it found that when the interval between an abnormal mammogram and a biopsy exceeded 90 days, there was a 20% relative reduction in survival for patients diagnosed with breast cancer. So time matters yet again. Now, at the time that I read Bleeker's publication, I was director of a women's health center in downtown Los Angeles. Previously, I had been a program director at a cancer center, a researcher at a local academic cancer center, and had been involved in a number of innovative studies that were really about raising the standard of breast cancer. Intraoperative therapy, studies involving oncoplastic surgery, studies involving cryoablation, really game-changing innovations. Now, unfortunately, since I was being primarily offering those treatments at a cancer center, I had observed that, let's say there was a limited population of Los Angelinos that benefited from what I had to offer. It certainly was not a diverse population. So the opportunity to build and to lead the Women's Health Center and to develop a breast cancer program there that served the community was a very appealing thing to me. And so I left USC, which is where I had been working, to head this center. And at the center, I assembled a multidisciplinary team of breast care specialists that on a weekly basis met and discussed every single breast cancer patient that came through our door. Not a subset of patients, but we met and reviewed every single patient that came to us. We reviewed them for the usual treatment indications. Everyone was considered for clinical trial if appropriate. And, we provided, I think, amongst the highest level of care in Los Angeles, because we were providing not only comprehensive care, complete care to all patients, but also made sure that every patient had access to game-changing clinical trials that were not generally available to to patients going to other institutions. So I was pretty proud of what we were doing. But we did have some concerns that and challenges that were really difficult to overcome. Number one was that we found that patients were often quite delayed in getting to us, that meaning that they were diagnosed several months ago, and then they finally came to us for treatment. And once we got them into treatment, although we all were committed and available to treat them, it often took a long time to get them through the authorization process to surgery or to chemotherapy. And so this, paper that came to us that told us that time mattered and delays led to worse survival really drew attention to a need to look at this problem more closely. So I had one of our research assistants look at our experience over the previous year. We looked at the time to treatment for patients that were treated at our facility and stratified it by the intervals that were used in the Bleeker publication. What you can see here, and it was quite a disappointment to see the results, but it was the reality that we're dealing with, was that we had a median of 118 days, about 4 months, from time to biopsy to surgery. Now, most of the patients had a biopsy in the community and they came to us for treatment, but that time interval from their biopsy to the time that we actually got them to treatment, surgery, chemotherapy, was a median of 118 days, which means that half of the patients had their treatment completed after 4 months. Half were before 4 months or 118 days. The other half was after 118 days. And it was quite shocking that that was the reality, especially once we learned that after 60 days, there was a decline in survival. Here we are treating, median patients at 4 months, a median of 4 months, means that, meaning that, patients were already experiencing compromising survival by the time that we got them to the operating room or got them to neoadjuvant chemotherapy. Now, I did ask the team to stratify the data by pair types, because we did recognize that there were some patterns that emerged that were suspected. And as you see from the upper right of the slide, we found that for patients with HMO, about 80% of them had delays that were more than 60 days. Medicaid or Medi-Cal in California, 66% of them were delayed past 60 days. Medicare and PPO looked pretty good. About 20% of the patients had delays. So there were still delays that were significant, but much less than the other populations. Now, and these delays existed even though the delays were often related to authorizations, but the delays existed even though more than 90%, 95% of authorizations that were requested were approved. It's not like we were requesting things that health plans didn't approve. They just were very slow in the process of approving things like surgery that tended to delay completion or initiation of care. Now, the next thing we did was to say, well, we see who's coming in the door, but let's look at the community from which these patients are coming. And so we looked at, what we call the service planning areas of LA, shown here on the slide. And most of our patients came from service planning area 6, which is shown in the center. Now, there's some community names that you might recognize: Crenshaw, Inglewood, Watts, Compton. Those are cities within service planning area 6. And in fact, that's the population that predominantly came to our facility. Our facility is right here in downtown LA. So they were geographically in proximity to us. But SPA 6 was a population that we primarily served. And as it turns out, we were seeing these really terrible time to treatment numbers. But the question was, what does the community see as a whole? Because the pattern that we knew about before, the history that we knew about before, was that this area, SPA 6, historically has had amongst the worst cancer survival rates in Los Angeles County. So there's some things that are starting to make sense when we look at the delays that we see at our facility and historical delays and compromised cancer survival rates from SPA 6. So I did a cancer registry study asking them to provide me all the data for patients treated for breast cancer in SPA 6 and to stratify that data by time to treatment as well as by payer type. And this is basically the payer type stratification that we saw in this population. Now, the numbers for the population in 2015, when this analysis was initially done, looked in some ways better than what we had at our center, but they were still not great enough. There was a much lower delay amongst the HMO patients, which tells us we had really terrible HMO contacts at my hospital, since we had an 80% delay amongst HMO patients. But Medi-Cal patients, about half of them still had delays past 60 days. Medicare and PPO patients pretty much looked like what I showed you at the facility, that there were delays in a range of about 20%, but not significantly, or at least not as high as what we saw in the Medi-Cal patients population. These data are from 2015. I asked for the data to be updated more recently, and we looked at the patients treated between 2016 and 2021, and we saw some improvements, but basically the same take-home message, that patients with Medi-Cal, which is the lowest tier insurance, had the longest delays. About half had delays past 60 days. Medicare and PPO, again, consistently was in the 20% range. There were delays, but much fewer. And HMOs actually had improved, at least the way that they abstracted the data for HMO showed improvement. So that's an improvement over, what was seen before. But clearly, the patients with the lowest quality insurance had the longest delays and potentially the most significant compromised survival. That is what is emerging from this analysis. So why does this matter, and to what degree does it matter? Well, in order to understand the impact of these delays in a kind of a real world sense, you have to understand, take a look at the impact of the things that we do to improve survival. For example, we give chemotherapy to improve survival, to reduce the risk of death. We give endocrine therapy to reduce the risk of death. There have been a number of studies looking at, the global experience of giving chemotherapy, the global experience giving anti-estrogen therapy, and each of those studies show that chemotherapy reduces the relative risk of death by 30%. That hormonal therapy reduces the risk of death by about 30%. So, it'd be nice if it were greater, but the reality is the relative reduction is about 30%. So to understand what that means is, if your 10-year survival for breast cancer would be 10% without chemotherapy, and we give you chemotherapy, a 30% reduction in your mortality would be a reduction from 10% to 7%. it's a 3% absolute reduction, but it's a 30% relative reduction. Or if you went from 10 to 5, that's a 5% absolute reduction, but a 50% relative reduction. So what you get with chemotherapy is a 30% relative reduction, or you get from hormonal therapy a 30% relative reduction. So let's see how that stacks up against the negative impact of the delay of survival. So based on the Bleecker publication, a 90-day delay, that it means 60 days plus the additional 30 days, is associated with a 10% to 15% relative reduction in overall survival. If the delay is as long as 120 days, there's another 10 to 15% reduction in relative overall survival. If the magnitude of chemotherapy is 30% benefit, and the detriment or the harm of a delay is a 10 to 15 plus 10 to 15 compromise of survival, you can see how the impact of a 120-day delay would completely or almost completely negate the positive benefits of chemotherapy or the positive benefits of hormonal therapy. So essentially, we're giving patients chemotherapy to make up for the fact that we delay their care often and compromise the survival by the delay. It's almost unethical to think that you can give someone systemic chemotherapy, which has considerable potential harm, when there's no benefit potentially if the patient's care has been delayed by 60 to 90 days because of the challenges that the system sometimes imposes to get patients a treatment. So time matters, and if we want to maximize the benefit of chemotherapy and endocrine therapy, we have to minimize the negative impact of delays that compromise the value and the benefits of those treatments. Now, that discussion, how delays can compromise survival, brings a whole new lens to this slide that we've seen over the last couple of decades. At one point in America, survival or the mortality rate for breast cancer was the same for Black and white women. But over the last 3 decades, starting in the 80s, you see these curves diverge, higher death rates amongst Blacks compared to white, and those differences have been sustained. Breast cancer hasn't changed in the last 30 years. Breast cancer biology is the same. Breast cancer treatment is essentially the same in terms of what we give to different populations. They all get the same options, generally speaking. So there are some things that are contributing to this that we haven't quite quantified. I'm going to discuss a few of them in a moment, but I think the one thing that we haven't really captured and understood is how healthcare system imposes delays to care that adversely affect, to a greater degree, women with lower tier insurance, which more commonly are patients that look like us, meaning that they're African American or Hispanic. Now, when I was at the Women's Center as well, I had the opportunity to work with the Komen Foundation. At the time, they had established the African American Health Equity Initiative, which was an effort to understand disparities in breast cancer survival, Blacks versus white, focusing on 11 cities across the US. They looked at a number of things, some of which are summarized on the slide. They ultimately published a roadmap to save the lives of Black women in America, identifying the things listed here as potential barriers to potential challenges that need to be solved, barriers like overcoming barriers to early diagnosis, recognizing how aggressive cancer biology can contribute to disparities, recognizing how systemic racism and discrimination and lack of quality care can contribute to disparities, how patient-provider communication impacts it, lack of navigation, access to quality imaging, inequitable research, social determinants of health, and financial burden, how all these things can play a role in contributing to disparities in cancer outcomes, and how all these things require some attention in order to eliminate those disparities. But one thing that they didn't capture or articulate in a clear way, and I think I'm working with them now to kind of help them understand this, is that the time of treatment itself is a factor, and that the time of treatment, which is often limited not by things that originate from the patient, but by the barriers imposed by the healthcare system, often related to authorizations and so forth, can contribute to delays that not only make it an anxious, inconvenient process, but directly compromises cancer outcomes. The importance of timeliness is also becoming very important at the national level. There's a bill currently in Congress called Improving Seniors' Timely Access to Care. It's a bill that aims to hold accountable health plans for timeliness. As I said already, or certainly suggested, one of the major challenges with the timeliness of care is that many of the things that are fairly routine still have to go through a prior authorization process, which sometimes adds weeks to the time interval between biopsy and surgery, which again, wouldn't matter if it didn't necessarily compromise survival, but as you know now from the slides I've shared, it clearly does. And so keeping those delays limited is important. So fortunately, there's attention, as I said, being drawn to this, and this bill will require that health plans report to CMS the timeliness of care so that the outliers can be addressed. One of those outliers is actually based in California. This is actually an image from a news story that reported that one of the largest health plans in California, with over 2 million Medi-Cal patient lives, was fined $55 million because of delay of care. There were documented cases where patients, had care delayed that was associated with potentially their death. The health plan was a major barrier to care for these patients, and so they were fined as a result of it. This actually is the major health plan that serves SPA 6, which is the area that we had challenges with, or that we cared for at the Women's Center. And so, it was clear back in 2015 that they had a problem, and it wasn't until 2022 that kind of came to a head and led to the state finding this health plan $55 million as a penalty for delay of care. So what do you do about it? Well, back in 2015, when I first learned of the problem, I began to think about potential solutions. And initially, I worked on sort of a kind of human solution with a demonstration project that I was going to introduce with or develop with health plans to help put in place processes that would make their processes more efficient, getting a patient from a diagnosis to treatment. During COVID, I had a chance to kind of rethink the idea, and it emerged as not a kind of a human manual solution, but actually a software solution that was designed to streamline and automate patient clinical management and insurance prior authorization, with the goal of increasing the efficiency of care and also increasing the quality of care, making sure that all patients had the same minimum standard of care so that there wasn't great variance between some patients getting good quality care and some patients getting poor quality care. I wanted to standardize care based on guidelines. The software was designed to streamline the handling of medical orders and prior authorizations, to track and triage the initiation, scheduling, completion of orders with alerts at every step, so that if things were delayed, like the completion of a biopsy or the reporting of the biopsy to the provider or the referral to the surgeon, if those things exceeded certain time intervals, there was an alert that prompted a response. And then there was also an automated prior authorization process that was based upon a novel decision support tool that was disease-specific and guideline-driven. This solution was evaluated in a quality improvement initiative study that was conducted at a large hospital system in Nevada. They had a problem with complaints from providers and patients about the delay of care. They were particularly concerned about their Medicare Advantage patients, which should be the easiest ones to treat, but that's where their complaints were coming from. And so they were open to conducting a quality improvement initiative, utilizing this software prototype to see if it could improve their time to treatment. The primary aim of the study was to reduce the interval between the positive biopsy and treatment, either surgery or chemotherapy. The study group was to enroll all comers with abnormal imaging, BI-RADS 0, 4, or 5. The plan was to enroll them on the platform, manage them using the software, and to examine the time to treatment. Their historical time from biopsy to surgery, based upon the previous year, was 74 days. Our goal was to demonstrate that we could reduce it by half. That was the goal. We also, however, had a goal of trying to reduce it time from biopsy, positive biopsy, to surgery to less than 30 days, because although we clearly wanted to keep them under 60 days, we recognize that some patients might want to have a second opinion or might need to schedule surgery around some other life event, and that having a little wiggle room, another 30 days to keep them under 60 days, would be the ideal goal. There are also various secondary endpoints like reduction of overhead costs and identifying barriers to treatment. But the main primary endpoint was reduction in the time interval between a positive biopsy amongst those diagnosed with breast cancer and initiation of surgery or chemotherapy. The historical standard was, the historical time interval was 34 days. And so we set about the study to see if we can do better. But this slide summarizes some of our initial findings. In this quality improvement initiative, we enrolled a total of 552 patients. You see the distribution. There were some patients were BI-RADS 0 and then worked up and then reassigned to a different BI-RADS classification. Others came in as BI-RADS 4 or 5. Again, it was a total of 552 patients. 229 of those patients ended up with a biopsy. 72 of those biopsies were positive. 14 of those biopsies were high risk. 143 were benign. And so our study population was the 72 patients that were diagnosed with a malignant diagnosis, breast cancer. And our question was, can we get those through the process so that we reduce their time to treatment by 50% or greater compared to their historical 74 days? Here are the results. We were able to reduce their time interval from 74 days to 33 days. That meant that the patients had a 55% reduction in their time to treatment. Our goal was 50, so we met our primary endpoint. We exceeded the threshold that we had set. We didn't get the patients down to treatment within less than 30 days, but within 30 days or less. The actual number was 33, but that was still a really great outcome, we think. You must understand that we were working with a prototype, so it wasn't really kind of the final product, and the prototype was not integrated with their healthcare system, so we sometimes had delays in learning when something happened, so we couldn't actually act upon it to move it forward because we didn't have direct access to certain data that we had to rely on others to provide. But in either case, 33 days was less than exceeded our goal in terms of time reduction, and 33 days could be easily improved once we have integration with their healthcare system, with their EMR, so that we can directly access data that can drive the process. The initial studies results will be presented we hoped present them at the San Antonio Breast Cancer Symposium. We're waiting to hear if they've accepted our abstract, and we also have submitted them for the American Society of Breast Surgeons. So I hope they don't mind that I'm giving you a preview here, but they'll get more data than I'm sharing with you. But it really told us that, there is a way to approach this in a comprehensive, structured way based on using software, that we don't have to accept the history and the processes that health plans currently do, which sort of slow walk often the authorization, that process can move forward, and that there are many barriers, even in the clinician's office, that slow the process that we could expedite if we're just attentive to the details, and that's what the software allows us to do. Now, here's your summary. Treatment delay matters. It is common. In the Bleecker publication that I printed earlier, they estimated that significant delays only impacted about 3% of the patients. As you saw from our slides, it is a very common problem. It's a common problem amongst all health plans, but it's a particularly common problem for patients with lower tier health plans. It's a systemic problem. It is often limited or made more challenging by insurance company policies that delay decision-making, that leads to delays in patient care. Those delays reduce survival, and we must do something about them. And those delays disproportionately affect underserved populations and those with lower tier insurance, which unfortunately contributes to the disparities that we see, I think. My recommendation, given that this is, I think, a global or certainly national problem, is that each of you should examine delay times in your treatment setting or community, because I think it'll be an eye-opening experience. And of course, if you identify delays, I hope you can identify possible solutions so that you don't see such disparate results, with certain populations having significant delays that truly undermines their long-term survival. I also ask you to support legislation that demands accountability, such as the bill that I shared with you and others that may emerge over the coming years. So thank you again for the opportunity to discuss this important topic, and I'll be happy to entertain any questions.